So, what was it like running the country's largest and most extensive healthcare delivery system during a global pandemic, one that stressed every sector of government? Hello, everybody. My name is Teresa Carpenter, and welcome to the 153rd episode of the Stories of Service podcast. Ordinary people who do extraordinary work. I'm the host of Stories of Service. And on this episode, I'm going to be talking with Dr. Richard Stone, a physician, a combat veteran, and former head of the Veterans Health Administration. How are you doing today, sir?
I'm doing well, Teresa. Thank you so much for having me.
Well, thank you so much for being here. So, we're going to talk about so many things, but primarily, we're going to be talking about how starting in December 2019, his team at the VHA was tasked to perform the near impossible to not only care for those who served, but to take on what I believe is the fourth mission. I learned so much in this book of the VHA, which is the unprecedented natural disaster response mission of the pandemic that tested every leader and every resource available. We'll discuss Dr. Stone's best practices for calm leadership under fire and what he suggests for future pandemic responses. What best practices and lessons learned did he take from this crisis? And please ask your questions too. We are streaming live on YouTube, Facebook, and LinkedIn. So we'll get to your comments as we go through the call and let us know what you're thinking as we're talking about some of these subjects. So Dr. Stone served as the Acting Undersecretary for Health at the Veterans Health Administration, where he directed a healthcare system with an annual budget of approximately $68 billion, overseeing the delivery of care to more than 9 million enrolled veterans. Dr. Stone chronicled the challenges of leadership in crisis in his book, Save Every Life You Can, a reflection on leadership and saving lives during the COVID-19 pandemic, published in 2022. And in the book, he discusses the serious organizational and decision-making challenges faced while leading the nation's largest healthcare system throughout the COVID-19 pandemic. And I lost my place right there. Give me 1 second. Dr. Stone is retired from the U.S. Army, where he served as the U.S. Army's Deputy Surgeon General and the Deputy Commanding General of Support for U.S. Army MedCom. His final assignment was leading the operations cell of the Defense Health Agency transition team that developed business case analysis and business process reengineering for the 10 shared services assigned to the new Defense Health Agency. With extensive experience in civilian healthcare, he served on multiple nonprofit regional healthcare systems and has owned multiple businesses. Currently a practicing dermatologist, he obtained his training from the Wayne State affiliated programs in Detroit and the VA health system, and is a board-certified fellow in the American Academy of Dermatology. He has a number of awards and honors to his credit, including the Legion of Merit, Bronze Star, Combat Action Badge, and was a member of the Department of Defense Recovering Warrior Task Force from 2011 to 2015. Welcome again, Dr. Stone.
Teresa, thank you very much. Appreciate you having me.
Yes. So first off, I know you're born and raised in Michigan. Tell me a little bit about your childhood and how that parlayed into for an early career of, I think you went to college for a little bit and then joined the service, but I think it was with the selective service at first. You have a story in the book about that.
Yeah, I was in college at a time that the government instituted the lottery for the draft for Vietnam. And I was at that time prepared to join the military. And my number came up quite high in the lottery. I thought that was a pretty unfair system. I had people around me that came up below number 140, which is what they drew that year, and I decided to go ahead and join the military. My parents asked me to finish my pre-med training, and by the time I finished my medical school training, the war in Vietnam had ended. Had lost a number of friends during that time. And I just thought that the system didn't make much sense to me. I thought it was unfair. And so when I finished my training, life sort of happened and I started some businesses. I was working in the Midwest, as you had listed in the biographical background. And I decided in 1991 I'm sorry, 1990 to go ahead and join the military. Then about the time I was joining, Desert Storm occurred, and I really thought for most of my career that I had missed most combat experience. And then September 11th happened. And although I was in the reserves at the time, um, and was having a pretty successful career working for multiple nonprofits in the Midwest, helping to develop healthcare delivery systems. After September 11th, my life changed and my family's life changed. Spent the majority of the next 14 years on active duty voluntarily, and was deployed into Afghanistan, actually served as the surgeon for the current Secretary of Defense, Lloyd Austin, when he was a one-star in Afghanistan, and commanded most of the forces, most of the medical forces throughout that part of the war on terrorism in Afghanistan, Uzbekistan, Kyrgyzstan, and multinational task force. And when I came back, they asked me to do some work helping to stabilize the financial system of the defense health system. Did the process of the Defense Health Agency, of standing up the Defense Health Agency and making sure that we had clear goals on what we wanted to accomplish. Retired in 2014, and they asked me to come over to the VA to really work on access to health care and some of the problems in the VA system. As a veteran who was receiving my care from the VA, it was a labor of love. And so I went over for a number of years. And then when the Trump administration came in, I decided that as a disruptor, it was time for me to step back. Um, I did step back, went out to industry for a short time. And please don't take comment that I left at the beginning of the Trump administration as any political comment. For those people that know me well, know that I am not a political guy. I'm not a Republican. I'm not a Democrat. I thought as a uniformed officer, I needed to serve everyone. And if you ask me, am I a partisan? I certainly am a partisan towards the American veteran. So spent most of my time working to really stabilize the VA healthcare system and make sure that you as a veteran got appropriate access to care and that your family was well taken care of. And then COVID happened and everybody's life changed.
Yeah, yeah. Wow. What a backstory. Even from the beginning, when you just talked about the selective service, and you have a whole section in the book, Save Your Every Life You Can. And do apologize, I can't hold it up. I can hold up my Kindle, but in the book, what was that like? Because there are so few, I think, people who understand what it was like to be there in the draft period where you said, and I love this in the book, how you said the people you grew up with were the automakers and people that were going to go on and work in the industry. And then there were people like yourself who went on to college. What was the general feeling about people? Were people scared? I mean, I don't know what that must be like to have a draft and where you're in a position where you're forced. You're not. It's not just you're going to serve. It's you will serve. And how did the people around you react to that?
Well, not well. Remember, this was the late 1960s, early 1970s. And, there was a lot of anti government feeling at the time. There was very little positive view of the military. Now, look, my family goes back to military service every generation to, we can trace it back to the American Revolution on my mom's side. So
Hmm.
I don't think we were reflective of where especially the college students of the late 60s and 70s were. I think for those people, and 75% of my high school class went right into the auto industry, right into the auto plants, and they made good livings. They were very patriotic people.
Hmm.
And I think they were quite a bit different than the group that went on to college. But for those in college, fiercely independent individuals, not well oriented to the actions of the United States government, not terribly respectful to any forms of authority in that sort of hippie generation. And
Yep.
it was a tough place to be. And frankly, I think that most of that melted away after 9/11. And
Hmm.
so, for those of us that served in that period, we saw this tremendous feeling of patriotism towards the country.
Sure.
And for those of you that are still in uniform, this feeling of losing that level of respect for our military and for those people that serve us in our local communities in police and fire is very, very difficult to stomach. And it feels like there's a lot of backsliding. So tremendous fear. I talk in the book about, what it was like to sit with a Navy contract on my lap. And it was as they pulled the dates out, and they had it televised, and we all sat on the floor and sat in dorm rooms watching the draw of these dates, and your whole life changed based on whether your birthday was chosen. And
Right.
when
So
if your birthday
unfair.
was, yeah, and I just, I talk in the book about a guy that lived across the hall from me who
Hmm.
it was chosen as the number one, and his birthday was one day off from mine, and my birthday was April 25th. It was April 24th was the first date chosen, and he quit school that night
Yep.
and
I-
went off and joined the military,
It's just one of
and
those
I
things
talk
that
about
we,
that.
yep. It's one of those things that I think that our generation, even my generation, doesn't completely understand. My father was also drafted, and he was going through college at the time, and he was a broadcaster, a communications major, and so he was able to join the army and then go into and be. He worked at Armed Forces Radio and Television in Panama during those years, but I would think that most people just wanted, if I was in that position, I would just want to get ahead of it and say, okay, I'm going to serve. I'm going to step up for my country, and I'm going to try to do my best to join the branch that I want to join and do a job within the military that will allow me to utilize the skill sets that I have to make the most of an impact. I
Yeah, it took me probably 20 years to close that loop, and or almost 20 years to close that loop, just because my training was so long. I trained in internal medicine and then in dermatology, and then life just sort of happened, and but it never felt right to me that this is how things went, and I talk about some stories of what happened to that individual that joined that night. He was eventually killed.
Yeah. And I mean,
But
and that's what I
no,
mean. I mean, just for people who don't there's no choice involved. I mean, and I don't really have the best solution for that. I mean, they've even talked about that today, that there could come a time uh in our recent history or going forward where a draft might have to be instituted again. And that there's it must, and I would think too, even as a person in a leadership position, knowing that people are drafted or conscripted versus if they want to join and they're volunteering to join, I feel like there's just a difference, because when people volunteer, there's that intrinsic motivation, like this is their choice, this is what they wanted to do, versus someone who doesn't want to do that. So it is a really difficult, I think, thing for people to contend with if it's not something that they know or that they thought that they were going to be doing.
yeah, I have a dear friend who's a Vietnam veteran and was a product of the draft, and he speaks very highly of the draft military bringing every segment of society
Yeah,
into service to the nation, and how much that changed many people. I'm having grown up now with a volunteer military and served in an all volunteer military, taken to combat, volunteer units and volunteer soldiers. I must tell you that I think it'll be a sad day if America cannot fill its ranks with
hmm,
volunteers.
I agree.
And I'm all in when it comes to the all volunteer military. But I will tell you that filling the ranks these days is very, very difficult,
I know.
and there's lots of reasons for that, and that's a whole nother discussion in another podcast.
Yeah, for sure, for sure. So, one of the lessons learned that you had in Afghanistan that you took with you during the COVID response was this idea of this integrated command center. And I wanted you to kind of expand upon that a little bit. I really, no, I thought that was really good. This whole idea of sort of a command and control hub where there was consensus building and different views were actually appreciated or welcomed. Can you tell me a little bit about that?
Yeah, I mean, I think for all of your listeners that have been deployed to combat, they've experienced some version of this. But in Bagram, Afghanistan, there was an inflatable, what looked like a golf dome, and it was higher on one side than the other side. And you came in, and there was literally the entire war was being managed from that inflatable dome. And the beauty of it was twice a day, in less than 45 minutes, every portion of the war reported to the commanding general. And there was open discussion. My part running the healthcare operations, my responsibility was to understand very clearly what the demands on the healthcare system was going to be in the next 24 hours or in the next 12 hours if we were doing another briefing in 12, and making sure that the commanding general and leadership understood what my challenges were. Was I out of blood? Was I out of beds? Was there a shortage of burn beds? Was there a shortage of medications? Was there difficulty in evacuation? And to do that in a very brief, concise manner
I
so
like
that
that part.
commanding general understood. Now,
Hmm.
there's two things that have to be understood. The senior leader's got to listen. Senior leader will not get the benefit of this if they're not openly listening. So therefore, um, the commanding general, who at that time was Lloyd Austin, would sit very quietly and then comment at the end or make immediate corrections if somebody was off kilter. It was also clear from fellow, and usually these were O6 commanders that were briefing the general, and I was an O6 at the time. Uh, you briefed only if necessary. If there was frankly nothing to report, there was that's exactly what you said, and you moved on to the next person. So you could get through work very, very quickly. So it impressed me how effective this was, and how there was never any interpretation of what the boss wanted and what the commanding general wanted. So when I got to the VA, nothing like this existed. Literally, the chief of operations was managing 175 hospitals and 1,200 sites of care off of a telephone and calling people up. And nobody knew anything about what anybody else was doing. So we established an operations center, and we did it as part of the stand up of something called the Mission Act, which transformed VA's access to health care, and was done after the access crisis of Phoenix. And then we tested that with the rollout of the Mission Act in 2018. And we used it during hurricanes and earthquakes. We used it during the Puerto Rican earthquake. We used it for hurricanes across the country, fires, where the VA, as part of its fourth mission, would come in and help.
Yep.
And I use the example that after the Pulse nightclub shooting in Orlando,
Hmm.
overnight, I put 46 or 47 psychologists on the ground to help federal law enforcement reunite families with their deceased loved ones. And it was really tough work. But nobody knew we were there, but we managed all of that from the operations center.
Yeah,
So
I had
along
no
comes,
idea that there was a disaster mission for the VHA. I mean, I do remember during COVID that they were deploying people from DoD, but I didn't know that there was basically four missions of the VHA. There's, of course, treating America's veterans, teaching, education, and then the disaster response mission. And that's something that you even say in the book, too. A lot of people don't know much about.
yeah, and we operate it that way. We operate it very quietly. First of all, most communities are not terribly excited when their healthcare systems are overwhelmed or decompress. And so that we come in and we really try to work as much behind the scenes as we can. And I say that, but we would roll in, large numbers of rolling stock. I had over 300 pieces of rolling equipment that could establish anything from a 20-bed ICU to a mobile pharmacy to a feeding unit that could feed about 3,000 people in a community in a day. And we would move these very, very quickly. We managed that out of some alternative COOP sites for the United States government. But we would manage going back to the Health Operations Center, gave us the ability to really transparently operate and correct problems. And let me give you an example of that. When New Orleans was being overwhelmed with COVID, the commercial healthcare system just didn't react very well. And when I say that, it's a very competitive system in New Orleans. And it's hard to get people to move away from competing with the hospital down the street. If I'm running, the hospital at Emory, just hard. And they got overwhelmed pretty quickly. And luckily, when we had rebuilt after Katrina, the VA hospital in New Orleans, we built it as an ultimately configurable hospital. And we had a brilliant medical center director there and a regional leader who shared that brilliance. And when they designed the hospital, we could convert that entire hospital into an ICU. And literally it became overnight a 100-bed ICU to take the sickest patients that we could. It was my vision that anybody could take care of sort of minimally ill patients. And remember when the hospital ship got to New York Harbor, they said, well, we're not going to take COVID. We're going to take everybody else to unload the healthcare system. We took the opposite view, and that is we wanted to take absolutely the sickest patients because they consumed the most resources. And we felt we were better because of our size to take that. So in the process of converting to this 100-bed ICU, the medical center director in New Orleans realized they didn't have enough critical care nurses and they didn't have enough ventilators.
Mm-hmm.
And during that open call where they identified those weaknesses in the system, I didn't have to do anything. I literally sat there while the Minneapolis medical center director said, I can send you 16 ventilators. In fact, I've got a truck moving right now
That's
to pick
great.
up the ventilators. They will be on the road. By tomorrow morning, they will be in New Orleans.
Mm-hmm.
And those are the sort of things you can do with open and transparent work
Yep.
that people just don't quite realize the absolute difficulty. Now, I want you to think about if you're in a commercial healthcare system in America, giving up, a couple $1 million worth of equipment and having it shipped to your competitor hospital. Number one, you don't know if you're going to get it back.
Mm-hmm.
Number two, who's going to have my back when I get in trouble? So that Minneapolis director had this tremendous, I mean, it was a perfect example of what I wanted in the VA. And that is people to trust that leadership would have your back if you got in trouble. And as you might remember, early in the pandemic, the upper Midwest had very little COVID, and they weren't being tested significantly. Now, they were eventually, and it became a very difficult situation in the Minneapolis-St. Paul area. And we moved equipment back.
Mm-hmm.
And being able to do that quickly and manage those logistics, I think, is one of the messages of some of the logistics challenges of the American healthcare system and how difficult it is today.
Yeah, one of the things that really struck me was the discussion in the book about Vice President Pence's healthcare task force that he set up during the pandemic and how that was just a ad hoc agency and that there really isn't any kind of a federal mandate or any kind of I think there's no system that's bringing together all these different commercial hospitals or like you said, the Indian Health Service and the VHA and the DoD Health Agency to all come together and be integrated into some sort of a functional functional group, working group, let's say, that meets daily when something like this happens.
Yeah. After World War II, the United States recognized that part of the response to World War II was not as good as it should be, and they stood up the National Security Council. And the National Security Council's responsibility is when the President of the United States sees a threat to the nation, the National Security Council takes that on and really begins to develop options for the president and really direct the actions of the United States government. So since 1947, that's been tested and corrected and matured. There is nothing like that in American healthcare. Now, there's been no global threat to the American population like COVID for 100 years, since the 1918 pandemic.
Mm-hmm.
And because there's been no challenge like that, no one felt called upon to move this in the right direction. And so you had people like the governor of New York who really did not understand how to respond to this, screaming for, 16,000 ventilators. Now he eventually got 6,000, but that 6,000 ultimately depleted most of the supplies. And I use the example in the book of, can you imagine being in the midst of a war and having a governor and the president of the United States debating how much ammunition you're going to give to each unit? It
Yeah.
was ludicrous.
Yeah.
And
That metaphor hit home for
I,
me.
I don't want your listeners to take this as a criticism of Pence. He was doing his best.
Mm-hmm.
But what he didn't have the benefit of is real healthcare delivery experts. So he went to public health experts. And, Dr. Fauci, Dr. Burke, I mean, these are brilliant people, but they're not healthcare delivery experts. They are public health, and they didn't understand the complexity of really trying to manage the movement of medical materials for the benefit of the American people. And at the end of the book, I actually give a whole list of things that Congress ought to do, and gave some testimony at the in December of 2021 before the House of Representatives as a civilian, recommending the changes that need to be done. I can tell you that there's been a little bit of movement, but
Mm-hmm.
not a lot. And I don't think this country is terribly well prepared. And I've done some presentations on what a national security threat I find this, that the American people are terribly vulnerable, that should, monkeypox emerge as something different than it is today in the Congo, or we see an Ebola crisis, or we see some other type of virus come forward like COVID, how much danger there is to the American people. Now, in addition to that, we were blessed with a pretty robust Department of Defense response that was able to provide some very nice work across the United States. What if the United States had been in an active war at that time where that healthcare system was
Mm.
not available?
Yeah. Good
I
point.
think the VA is huge. I mean, 400,000 employees, more than 100,000 providers, a huge capacity. But if the VA is expected to be the sole responder, then I think there needs to be an honest and open debate about how we prepare the VA most effectively for that. And I was blessed with some pretty strong leadership across this delivery system. And it worked out very well, and we saved thousands of lives. And I, I think the other thing that I failed to recognize as a uniformed guy from the military, I was used to being able to order people to go to places I wanted. In the VA, these are all civilians. They had to volunteer to go. And as
Mm-hmm.
much as we'd done well in earthquake or hurricane response, when we did that, the risk was already passed. I was
Mm-hmm.
asking people to go to some very difficult areas. Some of the most difficult areas were nursing homes in America. And those nursing homes had active infections, uncontrolled spread of those infections. And I talk in the book that there was a very substantial risk to these employees, and but yet they volunteered. Now, I'm not
Hmm.
going to tell you it was easy, nor could I get people, and I often lamented the fact that I couldn't just order people to go places. They were all volunteers, which reflects the fact of how really effective and dedicated to the mission the employees of the VA are. And I think that comes through in the book of what
It does.
how much I really admire the employees of the Veterans Administration and how dedicated they are to the mission.
Yeah, it really is. And one of the things too, I think that struck me so much in the book was how you were able to do this mission in spite of everything that would be working against you. You had all these roadblocks or moments in the book where it just seemed like it was insurmountable to get something done. And one of the things that I always wondered as I was just reading through the pages and the different chapters, because each chapter is sort of a different section of this crisis, was how much did the politicization of COVID impact you? Because one of the things I hadn't thought about, and you mentioned it in the book, is that during the pandemic in 1919, the same kind of politicization and misinformation and things about COVID that we saw were happening back then. But the difference is today we have social media and sort of this instantaneous communication channels, and I'm curious at how much of any of that, of the misinformation about the vaccine or some of the different narratives that were going on around COVID, how did that impact your ability to do the job?
Every day, every day. And I use the example in the book that I use a book called The Great Influenza, 1918, the story of the 1918 influenza. It started in the military, right? When the United States military was mobilizing for World War One, and these that influenza affected mainly young people with very strong immune systems, where their immune system would become activated by the influenza virus and resulted in tremendous death rates and really ugly deaths across the nation. But that was also politicized. And because America was trying to maintain an effort towards World War One and deploying into Europe, which there was tremendous feeling across the American public of not wanting to get involved in Europe.
Hmm.
And there was tremendous misinformation and blocking of information coming out, really similar to what we
I know
dealt
that. I
with.
found that interesting. I didn't know it was
And
so it was the same kind of thing.
in fact, Teresa, it's one of the things that people, when they encouraged me to write the book, they said to me, "Well, what if you hadn't had the Great Influenza book on your shelf? What if you hadn't forced Rich to force the leadership team to read that book in December of 2019 to understand what was going to happen to us?" We tried to see the future, though. One of the ways you see the future is to look at the past really clearly. And we wrote this book because 100 years from now, I want somebody to look at this
Mhm.
and have this on their shelf and say, what really happened here? And so, we've been very transparent with AARs and some of the stuff we've generated, and it hasn't always been pretty, and it's created some congressional testimony and some media interest that hasn't been terribly positive, but I think you expose your weaknesses. I think the other thing you expose, and I think when you're in crises like this, we in government have a tendency to try and wait until we get everything 100% right, so we reduce risk.
Mhm.
I think you have to take risk in crises,
Yep, you
and
talk about that.
I follow the 60% rule. Get to a greater likelihood that you're going to be successful than fail,
Mhm.
and then make a decision and run. But do it so transparently that if you made a bad decision, that you're willing to come back and revisit and that requires you check your ego at the door. And I use the example of Manhattan. I had this idea early in the pandemic when New York was in such trouble with the cases that I could take my Manhattan hospital, make it a COVID hospital. I could take my Bronx hospital and make it COVID free. Well, that was a great decision, I thought. two close together hospitals separated by the boroughs of New York. Well, nobody told the virus, and
Right.
nobody told veterans. And veterans felt comfortable at the Bronx hospital, the Manhattan hospital, so they just went there. They
Went to what
didn't
they
know
knew.
they had
Yeah.
COVID. They knew they were sick. And very quickly, that turned out to be a bad decision. And we very openly um, publicized that across the operations center so everybody saw it. And the value to my leaders was they saw me check my ego and go, no, I made a mistake here. We're going in a different direction. Now, what we did was we established COVID positive and COVID negative neighborhoods within each hospital and each nursing home. Now, I want you to think about the mess in New York and the amount of deaths that occurred in New York and in Hawaii and in a number of other areas of the country in nursing homes where they couldn't establish those neighborhoods. They didn't understand how to do that work. And
Hmm.
that was the mistake the governor of New York made. He didn't understand when he ordered the discharge from his acute care hospitals that were overwhelmed, all well intended, to nursing homes. He didn't understand their inability in those nursing homes to prevent the spread of the disease because they didn't understand how to do real infection control. And therefore, we were in hundreds of commercial nursing homes helping teach people how to do effective infection control and saved just countless lives. But, you know, in New York, New Jersey, Hawaii, there is a myriad of stories of hundreds of civilians who died of COVID because they were infected by an inability of the employee base to understand how to manage infection.
Yeah, yeah, it's unfortunate, and I don't think I had a true understanding until I read the book about the protocols that are needed to maintain, like you say, those COVID-free neighborhoods and within a hospital, or and then the places that are affected, and even just the transfer of care. You have a whole section in there about how if someone comes from the commercial system and they come into the VHA system, there really isn't an electronic mechanism within crisis to transfer all those records or all those lab results. And you were saying in the book about a lot of times it would just have to be a face-to-face handoff between the care providers with the patients.
Yeah, I think all of us are used to watching various series on healthcare systems and things like Chicago Fire or
Hmm.
Chicago Med, where people talk to each other pretty effectively in emergency response systems. None of that exists between DoD and VA talking to commercial healthcare systems. There is no
Yeah, I had
communication
no idea
system.
about that.
And we all did it by cell phones. And it was literally somebody saying, does anybody know the chief of staff at X hospital in St. Louis? And if you do, let's open up a communication with them and see what we can do. I had that in Detroit, in my hometown, where it just so happened that my regional medical director, who was operating out of Ann Arbor, um, knew most of the leaders of the healthcare systems across southeastern Michigan. And when they got overwhelmed, she was able to literally pick up her cell phone and call everybody and say, what do you need? And we took a huge number of patients off of their hands in order to help unload them of their sickest patients. And that was our requirement. Give us your sickest. And
Hmm.
allow us to take those that are at greatest risk. And what people don't know, you talked about the four missions of the VA. The VA has an extraordinary intensive care system, and we operate thousands of ICU beds, and survival is really high, and very advanced intensive care capability across the VA. And so we did very well by taking that population. The other area that we had a huge effect was with the Native American population. I learned a lot. I did not realize that many Native American tribes opt out of the Indian Health Service the Alaskan Native population, the Navajo Nation, opts out of the
Hmm.
Indian Health Service and operates their own. The poorer tribes in the upper western Midwest are still part of the Indian Health Service. Terribly fragmented system, and they needed help, but because the culture of the Native American population required so much sensitivity, we actually sent our employees into those hospitals instead of moving Native American critically ill patients to us. We just
Mhm.
thought it would work better, especially with end of life issues for people with a high probability of death. And it worked out much better. But I learned a lot about, number one, the quality of the Navajo system, health system, the Alaska Native system, really high quality systems. You know, you talked earlier about the 4 missions of the VA, and for your listeners, let me just go through those briefly. You talked about the fact that, you know, the responsibility is to care for American veterans, yes. But in addition to that, to do research on the diseases and the injuries that occur to veterans during their service. And that includes things like toxic exposure. DoD is wonderful at expertise in acute care of traumatic injuries, but the VA spends a lot of its time really researching toxic exposure and the diseases that occur more commonly after things like Agent Orange occurred in Vietnam, or depleted uranium in Desert Storm, or the toxic burn pits that occurred in the veterans of Operation Enduring Freedom and Iraqi Freedom. In addition to that, the VA trains huge numbers of residents and interns and nurses, respiratory therapists. It is the largest provider of medical education in the nation. Over 120,000 students show up every day across the VA. And you'll hear people say, well, let's just shut down the VA and let's send everybody out to the commercial healthcare system. What if we had actually done that? Number one, we would have collapsed the medical education system in America. Number two, there would be no safety net for the commercial healthcare system in America, and
Mhm.
Americans would have been on their own. And then the 4th mission is what you talked about, and that is to be the backstop of American healthcare systems when they're overwhelmed, either temporarily or on long term, and to provide support for that. And that's really what the book is about: is how to execute those 4 missions. And you know, when I informed Congress that we were going to execute this 4th mission, and that we were receiving requests from governors all over the country, universally they wanted to know, well, can you do your other 3 missions still? You know, the quid pro quo was you cannot compromise your ability to accept any American veteran and while you're doing this 4th mission for civilians. And it was exactly the same question that had been asked from me in Afghanistan. In Afghanistan, we were overwhelmed after
Mhm.
a school bombing
Yep.
by pediatric patients. And, you know, the universal question of my line leadership was, will any American soldier be denied care because you're taking an Afghani child? So these are pretty tough questions to
They
answer.
are.
And you know, we worked our way through, but I was very appreciative of the fact that I had experienced this before, as people were questioning me, right up through the President of the United States, if you're going to do this, can you still care for the American veteran effectively?
It's a hard question, and I think that until you're in that situation or until you've had experience doing it, you're not gonna necessarily know what to do, but this kinda goes back to what you said about crisis and risk. You can't perform a crisis effectively unless you're willing to take on some degree of risk, and that's part of what I think separates the leaders who succeed, and go forward even with that 60% rate of confidence that you have. and then the rest of the people that won't take those risks and then just can't handle it at all. Sometimes, and like you said, you have to be willing to change course, admit your mistakes, and then keep moving forward. And I think that's what, as I'm reading the book, I think that's what I think was the key to success, is that you were willing to change course, you were willing to move in a different direction, willing to go outside the box to ask for help in places where maybe people weren't used to working together. And I think that's where you got towards the end of the book, where you had all those recommendations. It really surprises me that there's not a centralized. I mean, I know that we've come up with the Genesis system, and I don't know a lot about it, which is reasons why I think some people are having a hard time enlisting at this point, but maybe they're getting better about that. But there has to be, in my mind, some sort of a centralized database or a bank from a healthcare standpoint of people's information, that any hospital, any commercial hospital, any VA, any government hospital can access about people's medical information. It just doesn't seem to make sense to me that there isn't something that's in place to do that.
Well, think about the fragmentation if you show up at an ER outside the military health system, um, or the VA. You're starting from scratch.
That's crazy.
And there is some health information exchange, and I think there's been some good initial steps in that. But it's a pretty scary system. And think of the frustration your family has when they say over and over again, we keep telling the story of our family member and what health issues they have, because they're starting over again. And it's part of why we must evolve the American healthcare system. And I do not think that I think that we ought to have a government system. I don't really care who owns the system, but these systems have to talk to each other.
Hmm.
And when they talk to each other, it is for the benefit of you and I. I have a dear friend who's an Italian doctor, and the Italians, in what I describe as typical Italian manner, well, they have a government-run system that runs really very well in the morning, and then the rich people at night and in the afternoon, all the doctors go take care of the rich people, but they keep their own medical records.
Hmm.
And I tell my friend, I'm sure it's because he's avoiding the taxation system. But the point, I'm not trying to be pejorative here. Um, but think about if you owned your own medical records, and I don't know where they're kept, and then gave providers the opportunity to access them
Yep.
when you needed care. You could take care of all these problems almost overnight.
Yep. Oh,
Instead, we've
oh, I
taken
know.
the approach of making industry talk to, in health information exchanges, and they've made some progress. But I really believe that my medical records are mine.
Yep, I
They're
do
not
too.
owned by DOD or by
Nope.
VA, and they ought to be transferable at my choice.
Yep. I've heard that there's even some commercial hospitals. I was listening to a podcast about this the other day, about where some people don't even have the right to access their own medical records. They can't get access to them without some sort of special permissions or some or what have you. I mean, that to me, that's just ridiculous. It should be something that you own and then you transfer easily to give access to whatever hospital it is that you're at, for them to just go into your file and immediately see your labs, see your scans, see everything that they need to see. It doesn't make any sense to me. And like you said, the burden of family members who might have to care for an aging member of their family, or somebody who's got a comorbid conditions, and then having to explain all these different conditions all over again to a new care center or whatever. It just seems ridiculous to me.
Um, it ridiculous, sad, frustrating. Um, there are systems, John Hopkins in Baltimore, that gives immediate access to patients to lab that comes out, and I mean, literally, you can see records of scans before the physician sees it,
Yeah, it's
and
great.
that's great. I have a dear friend who we just lost to breast cancer, and at her system in southeastern Michigan, um, it would take almost 3 weeks for the provider to call her and give her the results of that scan. Well, if you have
Mhm.
family members that have had serious illnesses, You live, it's like cancer. You live from scan to scan of,
Hmm.
is my life going to change with the results of that scan? And to wait 3 weeks for that, I find absolutely unacceptable.
Hmm.
And that needs to change. And hopefully there'll be an effort to do so. But
I hope so too. I think that an educated patient is overall a better patient, and I think it just helps everyone. Like you said, that the transparency will, in my view, level up the game. If everyone knows what their scans look like, if everyone knows what their doctor's notes look like, if everybody understands what's being said, they can share that information in an attempt to educate the community. Because as we know, medicine, like many things, it is changing. The technology gets better, it evolves, and I think we need the opportunity to be educated on that. One of the other things I just wanted to ask you about, and it's something that I've always wondered about, as I'm navigating some of the things that I spent years not getting documented, that now I, towards the end of my career, and spending time getting documented, is this idea of specialist versus a GP. And here's what I mean by that. I've noticed that a lot of times, at least it's in the private care system that I've been experiencing firsthand here in the UK, you have a GP, but the moment that you say you have an issue, you're immediately put onto the specialist path. Then you go down the specialist path for all this time. And sometimes I sense that maybe it's the GP's responsibility to do that. But do you think that there needs to be a system where there might be a holistic physician who looks at everything in a more broad manner, and then sees how some of these pieces fit together, versus I feel like sometimes we've gotten so specialized to the point where certain things are getting missed because everything is down this road to only see the specialist for this issue. Does that make sense what I'm asking?
well, it does. And what you're asking for is a care navigator,
Mm,
someone who knows you well that can help navigate care. Let me give you some examples of this, and it's something I used in the VA. Veteran with severe asthma on steroids for asthma, who also has type 2 diabetes on insulin. His commercial physician changed his steroid dose. It would mess up his sugar. He wouldn't know what to do with his insulin dose. His sugar would be messed up for weeks before he could actually get people to talk to him by the phone, because he'd call one specialist or another specialist, and he was his care navigator.
mhm,
We overcame that in the VA system by putting clinical pharmacists in charge of that type of complex care,
mhm,
because it was really about medication management effectively. And the clinical pharmacist would every Tuesday would with this friend of mine would have a call with the veteran saying, help me understand what's going on. I see that the lung doctor did this. I see the
mhm,
diabetic doctor did this. Let's reconcile that. And what you need is a partner to help manage this. I don't think that you should be expected as a non-medical person to navigate all this on your own.
mhm,
And therefore, what you use the term holistic, that's exactly what you want. You want someone who understands you completely and all the nuances of what's going on to help. Um, certainly the specialists need to do what they're doing, but you want to help people talk to each other. And so if at 9 o'clock in the morning, the clinical pharmacist talks to me on the phone about my two conditions uh, before 3 o'clock in the afternoon, that clinical pharmacist comes back to me and says, I've reconciled with everybody. Here's what we want you to do.
yep,
And then everybody knows what everybody else is doing,
yeah.
and nobody's operating in the dark.
Yep, because I don't feel like that the GPs, at least the one that I've seen here in the UK, hasn't. In fact, and I've gone to specialists in the DoD system as well through the MTFs, and the job of the GP doesn't seem to be to do that. The job of the GP is you go to them with a problem, and if it's something simple that doesn't require a specialist, they'll handle those issues. If it's something that's more intricate, they're just going to go straight down the path of putting you with a specialist until you go back and say, no, it's not this issue with my shoulder, it might be something else that might be causing this. I mean, I'm going through this issue right now with sleep apnea and having some difficulty sleeping and seeing if it's even sleep apnea and seeing what maybe it also could be. Could it be a deviated septum? Okay, well, now I got to go to an ENT person for a deviated septum. And so it's just these different conditions that I think are all in some ways, or is it stress? Because I have complex trauma PTSD. And so it's just interesting how it would be good if one day, like you said, there was this position of a care navigator that each person, each patient had, that they could talk to and would sort of understand how all these pieces work together.
And that's exactly the model that we've implemented inside the VA. That
That's
my
great.
primary care doctor really manages all of this, and it doesn't mean I won't see a specialist, but it is the responsibility of my primary care navigator to be at my shoulder to make sure that everything is fully understood.
I love it. I love it. So, as we're wrapping up the hour, I'm already seeing that we're getting close to the hour. It's been such a great conversation, and I highly, highly recommend everyone read the book, Save Every Life You Can. It's just a wonderful look. Like you said, 100 years from now, we might look back on this book and say, well, this was a really good example of how the largest and most extensive healthcare delivery system managed the most unprecedented pandemic in 100 years. And not only that, it's more about healthcare delivery systems in general and about what we can do to make these systems work better together and be more transparent and have more rapid access to services. Was there anything that I did not get to during this call that you wanted to address?
No, I think you've summarized it really well, Teresa. And I guess I would say one thing. Hidden within this book are amazing leadership lessons.
Yes.
And I think what makes you a leader that deserves to be followed? What makes you someone that people will take risk for? And those are within the pages of this book. And I ask your readers as they think about this to think about what type of leader they are, because we're all leaders at some level. Now, maybe it's 3 people or 400,000 like I had. Um, I, I think the question is what made me a leader that was worth following and for people to take risk for. And that is with what really the core of this book is, as well as an absolute admiration for the people of the VA and what they accomplished.
Yeah. I mean, there, like was telling you before the call, there's so many individual stories of people that just had amazing ideas. And of course, the one that resonated so well with me was the person who decided that you were going to every day do a video conferencing call to all the internal employees about what was happening at your level, and just the reception and the feedback that you got from that.
Yeah, I've always been a leader that worked by wandering around, and I spent the majority of my command time. I had 16 years of command in the military, and as well as in the VA, I wandered, and I was on the road most of the time, listening to people and trying to understand what was going on. When COVID came, I couldn't do that. And I didn't want someone else interpreting what I was thinking. Go back to my discussion of the operations center.
Mm-hmm.
And therefore, yeah, I had access to a video center. Was really a very advanced thing. I had all sorts of technology available. I found myself not very believable when we filmed stuff out of the video center. So literally, we took the telephone. When I walked in the morning, one of my staff picked up my cell phone and we recorded 2 to 3 minutes of what I was thinking about. And I was
I love it.
thinking about everything from my own kid with bilateral pneumonia from COVID, hospitalized in Florida, to, while I was up in Washington, D.C., trying to work on this, to were we really going to run out of masks and gloves? And, I saw the pictures of New York healthcare workers in garbage bags. And so we just talked about that. And I got huge response from that. Sometimes those were released at about 9 o'clock in the morning, and most of the command staffs would watch that as a group and then have a discussion. Sometimes 40,000 people would see that in the first couple of hours. And
Wow.
I never watch myself. I never listen to myself because I'm always unhappy with, how it looks. So, the deal was it was a first take. We just put it out.
Yeah.
They would put a little cover on it, and it would go out, and we tried to release it as openly as we could, and it was very, very effective. We made 255 of those over a year. And when I did travel, we talked about, what I learned from that. And I still run into people during book signings who say, I watched every one of those and here's what it meant to me.
That's so cool. I love it. I love it. Well, if you haven't read the book, you need to get the book. It's called Save Every Life You Can. It's by Dr. Richard Stone. It's a look at the unprecedented challenge that was undertaken by the VHA during the COVID tragedy. But it's not only about that. It's really about how we execute and manage America's largest healthcare delivery system and how we can make our healthcare system within America better. So I think it's just a wonderful contribution to our history. I really do. I think this book is going to live on. I'm so glad that your PR person, Amy, connected us because I wouldn't have known to read this book otherwise. And so I'm grateful that I had the chance to dig into this summer and read more about it. It's something I was always curious about too. So it was really interesting to read on the inside. And again, what I loved about it, and I told you this before the call, was that it wasn't just all the great things that happened. It was also about some of the things that could have been done better and then what you guys did to correct and remedy those issues. So I thought that was really nice, the transparency that you took in writing this book as well. So I appreciate that. And just thank you so much for being on the podcast.
Teresa, thanks so much. Good luck with your PCS.
All right. Well, thank you very much. And I will meet you backstage just to say goodbye very fast while I go full screen. But thank you all for joining me. And I will see you guys again this Saturday. I'm going to have on Tracer Burnout podcast hosts. They are a group of soon to be veterans. I think they're still active duty like myself. And they have teamed up, two of them, to form their own podcast. And I think it'll be great to talk to them about getting started and sharing stories of service. They have a very similar mission to my own. So I'm really excited to have them on the show, and hope you guys enjoy the rest of your evening. Thank you for joining us on this call. Please be sure to hit the subscribe button if you're following me from YouTube. Please recommend the show to your friends. And as I always close out the call, take care of yourself, take care of each other, and bye-bye now.